Hello, it's a real pleasure to be here, and I would love for you all to visit Baltimore. It's not quite as pretty as the last pictures, but it's a nice little city. So my talk is going to be pretty practical. I'm going to talk a little bit about how pulmonary disease manifests itself in people with ataxia-telangiectasia, some of the causes that we think may lead to pulmonary disease, how we diagnose it and monitor it, and I'll give you a few slides on our experience with the AT population, and then some of the possible treatments and therapeutics that may help. So just to kind of remind you guys that sinopulmonary disease was described as one of the cardinal features of AT back in 1958. The title of the article was Ataxia-Telangiectasia, a familial syndrome of progressive cerebellar ataxia, oculocutaneous telangiectasia, and frequent pulmonary infections. So it was recognized very early that this was part of the symptomatology of people with AT. And about 50% of people with AT will have some form of lung abnormalities. And complications due to lung disease are a major cause of morbidity and mortality in this population. Unfortunately, lung disease is often underappreciated and diagnosed fairly late in the course. And we also really, at this point, don't really quite understand the natural history of lung decline in AT. We don't have any biomarkers, although we're looking for them. And I'd like to talk a little bit about the role of lung inflammation and how that may play a role in progression of lung disease. So this is a little Venn diagram that we put together, and it kind of shows you that AT lung disease is different in different people, and sometimes people will have a combination of it. It's not uncommon to have recurrent sinopulmonary disease, so frequent sinus infections and lower respiratory tract infections, and often that's in the population that has some degree of immune deficiency. Some of the people will have significant bulbar and swallowing disorders, which can put them at risk for aspiration. And we also know that although people with AT do not have muscle weakness, they have discoordination of their muscles, and it can be difficult to initiate an effective cough, and that can make it difficult, particularly if you have a viral infection and can't clear your secretions. So you may be at higher risk for developing a pneumonia, even with a simple viral infection. And then, for some reason, a few of our patients, not a huge amount, but some will go on to develop something that we call interstitial lung disease that can be associated with a lot of problems with just oxygenation and breathing fast, and this can be very problematic in a small group of patients. So I just wanted to show you just a couple cases. Now this is a CT scan of the chest, and generally we try to avoid any type of irradiation. However, when we have somebody who is having significant lung symptoms, and it's clinically indicated, this is probably the best way of getting a look at the lungs so that we can go ahead and treat in the most effective manner. So we do occasionally do limited CT slices of the chest just to understand what's going on with the lung. So this was a 16-year-old who had recurrent lower respiratory tract infections, and when we looked at her lungs, it was quite obvious that she had quite a lot of infection going on, and probably had infection for a while. And this is something that we would call bronchiectasis, and that's when your airways become infected and you get recurrent infections, and that can be pretty problematic. And this child was treated with several different courses of IV antibiotics. We obviously want to avoid that, so it's really important to recognize early if you think a child's having respiratory problems, because we want to avoid this damage to the airways. This was another young man who started with some chronic cough and some swallowing issues, and he actually had a bronchoscopy, and that's a procedure in which you actually, you're under a little bit of anesthesia, and we actually go in and we do a washing of the lower airways. And we were able to tell that he had an infection down there, and then he was treated with that with antibiotics. He continued to have coughing and had a second bronchoscopy, which was negative, so we cleared out the infection. But we weren't really sure exactly what was going on, and he was really having significant coughing and respiratory problems. And when we looked at his CT scan, he was having these changes in his lungs that suggest that he might be starting to have an early interstitial process going on. And that may or may not be due to inflammation. And so we started him on some prednisone, and he did much better. So this is an example of perhaps some picking up somebody who has early interstitial lung disease. So what are the factors that increase the risk of lung injury in somebody with ataxia-telangiectasia? Well, we know that there may be a component of premature aging, and we know that just with normal aging, your lung function will decline. So we think that that may be playing a part in why some people are particularly at risk for lung problems. We also know that when you have an infection or an injury to your lower airways, you may have some problem with injury repair, and you could potentially have some scarring or changes in your airway. And then this is kind of a black box, but we think that inflammation and oxidative stress may also play a role in why some people have problems with their lungs. So, this kind of looks at some of the cellular mechanisms, and I really don't want to go into this in too much detail, but we do have some people at Hopkins and other places that are looking at telomere shortening. And these were fairly significant papers back in the 90s looking at whether or not people with ataxia-telangiectasia were at risk for telomere shortening or early senescence. We also think that there may be some dysregulation. So when you have injury, epithelial cells in the lungs and fibroblasts may not respond normally. The other thing that we're interested in looking is whether or not the macrophages are acting abnormally in somebody with ataxia-telangiectasia, especially if they're exposed to an infection. And we've done some studies in our population, and it was a cross-sectional study, where we just drew some blood and we looked at some inflammatory blood markers, one of them being interleukin-8. And IL-8 is a cytokine or a chemical that causes white cells to come to areas of usually injury or inflammation. And for whatever reason, we found that, at least in a cross-sectional group of our patients, these IL-8 levels were very high in the blood of some patients. And we think of IL-8 as a marker of inflammation. And so if you look on the y-axis, these are just the levels. And these are geometric means. So some of these kids had very, very high levels of IL-8. When you look at people who don't have ataxia-telangiectasia, they tend to be much lower. And then when you look at our group, and this was about 60 patients, many of them are in a pretty high range. Of course, a lot are also kind of in the normal range. So when we looked at some controls, where we looked at people with cystic fibrosis and people who were just controls and other people who had immune deficiency but were non-AT patients, we found that the mean for the IL-8, at least in our population that we looked at, was significantly higher than these other three groups. So what does that mean? We really don't exactly know what this means, and we're actually looking at this in a longitudinal study at this point. But it suggests that people with AT may have increased macrophage activation. So the macrophages are these inflammatory cells that produce cytokines, and they're very important cells, during injury repair and with infection. But if they're overactivated, they may overproduce inflammatory chemicals, and that could be damaging. So I think this is an important area to look at. So what we're doing currently is we're recruiting patients at our clinic to look prospectively at IL-8 levels and other inflammatory markers and to see if it changes longitudinally with time. And one of the things that we're interested in looking is at an antibiotic, azithromycin, because we know that azithromycin can modulate this pathway because IL-8 is downstream from this other inflammatory pathway, NF-kappa beta, and it's possible, although we have no idea yet, that perhaps azithromycin could modulate some of this inflammation in people with high levels.